Thank you for your kind introduction. It's an honor and pleasure to talk about this interesting hot topic in this round table with exceptional nephrologists. And of course, I would like to deeply thank Professor Kotsis, the President of the Congress, for his invitation once for one more year, and apologize for not being able to be there and participate in physical presence, although Chalkidiki is one of my favorite places. So I will continue by sharing my presentation. So as you heard, my today's topic is CKD, stroke, and dementia. And we, in the next few minutes, I will try to persuade that there is a link among these three entities. My disclosures. Okay. So, risk of cardiovascular morbidity and mortality increases with progression of CKD, and we know that cardiovascular disease remains the Achilles heel for our CKD patients. And we have to admit that we have mainly focused on the cardiovascular renal axis. So today we will focus on the kidney-brain axis, which was rather neglected, but during the last decade, it has come at the spotlight. And in the next 20 minutes, I will try to present all relevant, robust epidemiological, clinical, and experimental data supporting the theory that there is a strong link between CKD, stroke, and dementia. And I will start with epidemiological data showing that CKD patients have higher risk of stroke. Stroke actually is the third cause of cardiovascular death in our CKD patients. We see here in the left part of the slide that stroke incidence in CKD patients is high. It starts early in our non-dialysis CKD patients at a prevalence of 13.4 over 1,000 person years. It goes higher in dialysis patients, and it remains high in kidney transplant recipients versus general population. Recent data from the US Renal Data System, the annual report of 2022, it has shown that incident end-stage renal disease patients overall have around 9% of a previous cerebrovascular accident or transient ischemic attack. So here I present you a big meta-analysis investigating the stroke risk in our CKD patients. Actually, in the slide, you can see three big meta-analyses, and showing that an eGFR below 60 was an independent risk for future stroke, 43% greater versus normal eGFR. Moreover, for every 10 ml per minute decrease in eGFR, the risk of having a stroke increases by 7%. And ischemic stroke remains the most common type of stroke among patients with non-dialysis CKD, while hemorrhagic stroke is more prevalent in dialysis and stage kidney disease patients. In the same line, it is data about proteinuria, which might be a better predictor of stroke risk in CKD than eGFR, possible as an indicator of microvascular disease. Again, we have here three big meta-analyses, and the third one on the slide is a big meta-analysis which was published in Nephrology Dialysis Transplantation Journal some years ago. Actually, it included 63 cohort studies, almost 2 million participants and 20 randomized control trials, and it showed that 25 milligrams per millimole increase in ACR was associated with a 10% increase risk of stroke, while the effect of albuminuria was independent of the level of the eGFR. But it is not, but it is not only the incidence of stroke which is high in CKD. Uremia is associated with worse stroke outcomes, and as we can see in this slide, we have greater likelihood of hospitalization, dialysis initiation, and high short and long-term mortality. It is very difficult to discriminate between the net CKD effect from the coexisting risk factors effect on the cardiovascular burden of our CKD patients, no matter how well we adjust for confounders. In this big meta-analysis by Kelly et al., they aim to investigate whether low eGFR is a risk factor for stroke independent of traditional cardiovascular risk factors, and particularly from hypertension. And as you can see, they found there was an association of low eGFR, but the association between CKD and stroke appears to be highly dependent of the method of adjustment for hypertension. And now we move to epidemiological data trying to link CKD with dementia. Actually, research clinical findings regarding the kidney function markers and cognitive dysfunction risk have been mixed during the last years. Neurocognitive disorders comprise of 3 syndromes according to the DSM-5, and these 3 syndromes are delirium, mild neurocognitive dysfunction, and major neurocognitive dysfunction or dementia. And then major and minor neurocognitive dysfunction are further subtyped according to etiology, including Alzheimer's disease and vascular dementia. Regarding MIC, is the only a risk factor state for dementia. MCI prevalence increases with CKD states and possible also with the time spent at each stage, while 5 to 10% of patients with MCI will eventually progress to clinical dementia. Dementia incidence and prevalence is high in end-stage kidney disease patients and even in KTRs, although, as we can see, kidney transplantation seems to improve cognitive function. And screening for cognitive dysfunction in CKD patients is particular beneficial in our patients. Actually, what we should do to our patients is try to start early this course of screening in our patient at the early stages of CKD, and actually we have to do it consecutively and prospectively measurements so that each patient will be the control of him or herself. And this kind of strategy will help us answering a hot question, which is if early CKD has a direct link with cognitive dysfunction, because it seems that in early CKD stages, the direct link at the time point that cognitive dysfunction is initiated is not clear. This is a cross-sectional study from the regards cohort published 15 years ago in American Journal of Kidney Disease from Kurella Tamura team. And it included actually more than 2,300 participants. And they reported that CKD below 60 ml per minute was associated with an increased prevalence of cognitive impairment independent of confounding factors. And again, they showed that for each 10 ml per minute decrease in eGFR, there was an increase in the prevalence of cognitive dysfunction at a level of 11%. So we go to the SPRINT trial, which we all know. In this SPRINT trial, they showed that there is an increased incidence of dementia in comparison with general population at 3.8%, and also an incidence of mild cognitive impairment at a level of 7.6%. And they show that baseline eGFR below 60 and an ACR above 30 milligrams per gram were not associated with risk of dementia or MCI. Instead, they found that incident drop of eGFR below 60 and the eGFR decline by more than 30% were associated with a higher risk of dementia and MCI. Results from the SCREEN trial, which is a health cohort in Stockholm, with, as you can see, a big number of participants above 65 years old, elderly people. They showed that they have 1,800 incident cases of dementia, and they found that a lower eGFR between 30 and 55 ml was associated with higher dementia risk versus normal eGFR, and again, a steeper eGFR decline above 2 ml per minute per year was associated with a higher risk of dementia. Another publication from the ARIC study put another on the table another parameter regarding eGFR, the marker we use to calculate eGFR, and they showed that low eGFR based on cystatin C or beta-2 microglobulin, but not creatinine, were associated with higher risk of dementia. And they verified that albuminuria is consistently associated with dementia incidence. And coming to the last epidemiological and clinical study trying to connect CKD with dementia, this is a big study and well-designed, and a study published in JAMA Network Open just this year, 2023. And they tried to investigate, as I told you, the link between CKD and dementia. So they found that the cumulative all-cause incidence of dementia was at 8.2 within the 17 years follow-up. And they found that reduced kidney function was associated with increased levels of dementia-related blood biomarkers, but not increased dementia risk after adjustment for confounders. So they comment that kidney function might influence the accuracy of dementia-related blood biomarkers, and we should be very careful in this issue. So to summarize, as we can see, there is a discrepancy between studies regarding MIC and dementia in CKD patients, and some possible explanations about this is the differences in study design, the differences in outcome ascertainment, and also the differences in detection bias, survival bias, and also misclassification bias. And just one slide about the CONNECT project. CONNECT project is a multidisciplinary network of different categories of scientists with the specific aim to consider all factors that may influence brain function and shed light on those that impact the progression of mild cognitive impairment in chronic kidney disease. This project actually is a running project. You see that there are many different specialties they're implicated in this project: nephrologists, neurologists, preclinical kidney science, and bioinformatics experts. And this project includes a number of centers all over Europe. We have some Greek centers participating in this project, and we hope that Connect project will give answers to remaining questions and fill in the basic gaps. So to close the circle, I will just say with this slide that stroke is associated with an increased risk of subsequent dementia, and actually it has been shown that dementia incidence is nearly 50 times higher in the year after a major stroke compared with that in the general population. So in the next part of the presentation, I will briefly refer to pathophysiological data linking the three entities, CKD, stroke, and dementia. The kidney and the brain share anatomical and functional characteristics, making them vulnerable to similar vascular risk factors. Thus, these organs requires continuous, stable, high blood flow in a low vascular resistance system. They depend on short, small perforating arterioles, which autoregulate perfusion pressure, and for these reasons are susceptible to traditional atherosclerotic risk factors. Still, the burden of cerebrovascular disease in CKD, it is not explained by traditional vascular risk factors alone, and we know it for the whole entity of cardiovascular disease in our patients. We know that above traditional risk factors, there are other non-traditional specific risk factors in our CKD patients, and some of them are the renal specific risk factors, such as chronic inflammation, oxidative stress, vitamin D deficiency, clotho deficiency, anemia, uremic toxins, and all of these traditional and non-traditional factors seems to be part of a very complex puzzle. And all of this at the end regarding the brain, they cause brain injury in the type of stroke, small vessel disease, and cognitive impairment. Subsequently, I will address recent knowledge which we have gathered from preclinical and clinical studies aiming to shed light on the mechanism of brain damage in CKD. Experimental studies regarding the effect of uremic milieu on stroke and cognitive impairment are relatively few. In this elegant study, experimental study, Hellat et al. Actually perform a transient mild cerebral artery occlusion in mice with CKD, in female CKD mice, and they compare it to control mice. And what they saw that the CKD mice had worsened cerebral infarct volume size and functional recovery. They saw the amplified stroke-induced apoptosis and neuronal loss, impaired M2 and attenuated M1 polarization of the microglia macrophages in the ischemic brain, decrease of AMP kinase phosphorylation in ischemic brain, and amplified astrogliosis within the ischemic penumbra. In this very extensive and comprehensive review of Liabeuf and Associates on behalf of the Connect group, they address the until now existing evidence on the potential adverse role of uremic toxins, the cerebrovascular and neurological complications of CKD. And in the table, you can see 3 different categories of uremic toxins: the small water-soluble compounds, protein-bound compounds, and the middle molecules. And all of them, they could have possible direct and indirect harmful effect on the brain. Among them, recent experimental and clinical studies have tried to explore the neuropathogenic role of indoles, which are linked to direct endothelial toxicity. Actually, indoles and indoxyl sulfate are among the most studied uremic toxins linked to this direct endothelial toxicity. And in adenine-induced CKD model in rats, indoles showed direct toxic effects on the hippocampal neuronal cell line with increased numbers of pycnotic neuronal cells observed in the hippocampus. And in addition, indoles attenuated oxidative distress pathways and promoted neuroinflammation by increasing interleukin-6, which is a marker of inflammation, as we all know. The aryl hydrocarbon receptor pathway activation is a mediator of toxicity of indolic solids in vascular, cardio, and neuro damage in CKD. And it has been shown that indolic solids enhance thrombogenicity in the uremic milieu through the AHR signaling, which promote tissue factor expression in the vessel wall and triggers thrombosis. Blood-barrier brain dysfunction is associated with cognitive impairment in the neurodegenerative diseases and chronic systemic diseases like hypertension, diabetes mellitus, and the CKD disease. So potential mechanisms of endothelial barrier dysfunction in our CKD patients could be the disruption of the actin skeleton and also the decreased tight junctions in the proteins area. In this recently study by Bobot et al., they managed to show that the cognitive impairment in uremic rats correlated with serum levels of indoxyl sulfate and that BBB disruption as detected by the SPECT-CT imaging. The non-CKD AHR knockout mice were protected against the indolic sulfate-induced BBB disruption, showing similar relative brain content of 19.9 technetium DTPA regardless of the administration of indolic sulfate. And also, it seems that there is a strong association between cerebral small vessel disease and CKD, and it could be, and we can see it in the when we in CT scans and MRI scans, and it looks like the white matter hyperintensitives, known to us as eukaryosis, the silent cerebral infarction, perivascular spaces, and also cerebral microbleeds. And also, in brain imaging studies in CKD patients have identified that association between kidney biomarkers and the structural brain changes underlying the cognitive impairment in uremia. And they have again shown that albuminuria may be better capturing endothelial and microvascular damage in our CKD patients. So last but not least, I will refer to our end-stage kidney disease patients on dialysis. I presented previously that end-stage kidney disease patients are at higher risk for stroke and cognitive dysfunction, and one of the possible mechanisms could be the goal and regional cerebral hypoperfusion during dialysis. Here we can see two studies, and in both studies, they have found there was an impaired cerebrovascular autoregulations in patients with end-stage kidney disease on dialysis and increased susceptibility to cerebral ischemia during hemodialysis due to hemodynamic stress these patients have during the session. And the possible mechanisms could be inflammation, vascular calcification, and comorbidities such as diabetes, hypertension, atherosclerosis, and aging. So coming to the end of my presentation, I will sum up and present some future perspectives by saying that CKD is an important risk factor for cerebrovascular disease, that CKD frequently complicates routine stroke risk prediction, diagnosis, management, and prevention, and it is also associated with worse stroke severity outcomes and a high burden of silent cerebrovascular disease. The link between CKD and cognitive dysfunction remains challenging. Elucidation of pathogenesis of cognitive impairment in CKD is necessary. From an epidemiological point of view, it is crucial to discern independently causal association from intermediate mediators, confounders, and epiphenomena. And finally, large epidemiological prospective studies with CKD and healthy participants with appropriate screening tests, imaging tests, and novel CKD and neurodegenerative disease biomarkers are required so as to investigate the progression of brain changes and the relationship between kidney and brain function. Thank you very much.